I'm presenting my research project on the comparison of enteral and parenteral methods of urine alkalinization in patients receiving high-dose methotrexate. This project was developed after our institution experienced a critical shortage of parenteral sodium bicarbonate, which is the agent of choice for urine alkalinization in patients receiving high-dose methotrexate. These patients must receive urine alkalinization prior to their infusion to reduce accumulation in the renal tubules and to promote adequate methotrexate excretion. Our primary objective was to evaluate the time it took from the first dose of alkalinizing agent to the time the patients achieved their goal urine pH. Each patient has a pH goal established by their chemotherapy protocol that they must achieve prior to receiving their infusion. For my study, all the adults had a goal of greater than or equal to 7.5, and the pediatric patients had a goal of greater than or equal to 7. Our other objectives included time to methotrexate level deemed safe for discharge, total milliequivalent of sodium bicarbonate required, and toxicities associated with methotrexate and the alkalinizing agents. It was a retrospective cohort study comparing two groups of methotrexate courses. First was the enteral group, which were courses in which enteral sodium bicarbonate was used for alkalinization, and the other group was the parenteral group, which were courses with parenteral sodium bicarbonate used for alkalinization. The enteral courses were matched with a course from the parenteral group based on sample size and goal urine pH. At the bottom left-hand side of my poster, I included the dosing strategy we utilized for the enteral group. Courses in this group received either sodium bicarbonate tablets or sodium citrate citric acid suspension. The patient demographics are in Figure 2. We evaluated a total of 39 adult courses and 15 pediatric courses in each group. No difference in baseline characteristics except for serum creatinine, which we found to be higher in the parenteral group at baseline. Figure 3 represents the time from first dose of alkalinizing agent to goal urine pH achieved. Time in hours is on the y-axis and the study groups are on the x. We found no significant difference in this value between the two groups. Figure 4 has the time from first dose to methotrexate level deemed safe for discharge. And for my study, all adults had to achieve a goal of less than 0.2 micromolars per liter. In pediatrics, excretion was based off of 48-hour post-methotrexate infusion excretion pattern. Overall, no differences in this endpoint were found. We broke down the previous two endpoints by adult and pediatrics to further explore the data. When we evaluated it this way, we found a significant difference in the adult patients for the time to goal urine pH. However, although statistically different, there was only a 1.3-hour difference, which we don't deem to be clinically significant. Another finding was in the pediatric group, there was a significant difference in time to methotrexate levels safe for discharge. The enteral group took about 20 hours longer, but there was one outlier that took almost 200 hours to clear the methotrexate, which is likely the driving factor for this difference. Switching gears to our toxicity analysis, we assessed methotrexate toxicities by evaluating for acute kidney injury and hepatic injury based on change from baseline in serum lab values of serum creatinine, total bilirubin, ALT, and AST. We found no significant difference in any of these data points, indicating that neither route of alkalinization increased our patients' risk of methotrexate toxicities. We did find that the enteral group had a higher rate of stool counts, which was not surprising to us since the enteral forms of alkalinization utilized in this group were known to cause that effect. There was no difference in the gluvorin dose increases, and no patients required glucarpidase, which is the antidote for methotrexate. My study was not without its limitations. During the drug shortage, we are aware that some prescribers instructed their patients to begin taking enteral alkalinizing agents prior to admission, but due to inconsistent documentation of this, we were unable to ascertain the amount of doses the patients received. Additionally, for our parental group, we do know that oftentimes prescribers will instruct the nurses to increase or decrease the fluid rates without writing a new order, which makes it difficult to assess the exact milliequivalents of sodium bicarbonate these patients received. And other limitations of the study are listed for you on my poster. So in conclusion, enteral sodium bicarbonate was effectively and safely used as an alkalinizing agent during a drug shortage. Although we found a statistical difference in the time to goal urine pH in the adult groups, we do not deem this to be clinically significant. And moving forward, we will likely implement a similar strategy during any future shortages, and will hopefully have more adequate documentation of home administration of enteral alkalinizing agents.